फॉर्म्स नहीं रखा रहता हूँ।
हाँ
ये फॉर्म्स।
जब फॉर्म ले रखो बोला
हाँ फॉर्म्स लाना मालूम नहीं पड़े।
मेरे को नहीं मालूम तुम सारा मेरे को बोला आपको लगा मैं लगा दिया तो मेरा नाम आया Professor Gill. Professor Gill. Professor Gill. Did you like the flyer?
Yeah, that's fine. हाँ, मैं कल मैडम का वो देखा ना टॉपिक थोड़ा सा
Yeah.
से मेरे साथ फिर मैंने थोड़ा सा उसको टॉपिक को चेंज कर लिया क्योंकि मैं वन हेल्थ पे जरा कंसंट्रेट किया
Yeah.
पॉलिसी का या तो आई चेंज दैट टू स्लाइड्स दैट्स व्हाट आप मेन गवर्नमेंट का काम है
We are 25. It's very small. We are very bad. We are very good. Publication. We are around this much. Regular children. So I need to do it. How young woman scientists a job.
मेयर की तो अर्ली मीटिंग में पहले दो बार आया था
हाँ जी।
तो उसी दिन ये इसकी मीटिंग की वन हेल्थ की इसलिए हमने
Like one of the international conference that third February was officially will flyer is ready will share.
तो उस दिन आपके ना सब साइंटिस्ट का काम है
Oh.
उस दिन शाम को मीटिंग पे सुबह आपका
Dr. Subir Jit.
हाँ
Good morning, everybody. A warm welcome to everyone who is gathered here to commemorate the World One Health Day celebration today. So, as we have gathered here, we are also honored with the presence of two distinguished speakers: Professor J.P.S. Gill sir from Guru Anand Dev Veterinary and Animal Sciences University, Gadwasu, Ludhiana, and also Dr. Pragya D. Yadav, Director in charge of NIOH, National Institute of One Health at Nagpur. On behalf of NAB, we extend our greetings and warm welcome and thanks for coming in today and joining us. The World One Health Day is an international campaign. Basically, it is celebrated every year on 3rd November to create awareness and to promote the One Health approach. So, One Health approach is nothing but interconnectedness of the human, animal, the crop, the plant, and the environment, and a collaboration among all these sectors to ensure that once we protect one, we actually protect everybody. For this year, WHO has said that the theme is going to be My Health, My Right. This is because in 2021 data shows that almost half of the world population is not covered by health services. So to address these challenges, this year it is My Health, My Right. So I now welcome our director, Dr. G. Taru Sharma, to address the gathering before we start with the speakers.
Thank you very much, Dr. Madhuri. Good morning, one and all. And most welcome, Professor J.P.S. Gill, Honorable Vice Chancellor Gidwasu, and Dr. Pragya T. Yadav, Director in charge for a very important upcoming institute and IOH at Nagpur. And my own colleagues, scientists, students, fellows, and an IB fraternity. Greetings for World One Health Day. I think Madhuri has set up the tone. What is exactly the theme for this year? It's not only one day, but it's very important for all of us, as she rightly mentioned, and especially for National Institute of Animal Biotechnology. With all humility, we draw distinct pride in running country's first One Health program, which started in 2021, officially was conceptualized somewhere between 2019 and 2020. And this is a big consortia program. And what is more happiness in it that Professor J.P.S. Gill is one of our important consortia partner, a coordinator of one particular partnership within this One Health consortia. So this consortia has been doing in the beginning fairly well, and now not to boast, but doing well. And we are hopeful by the time we kind of close it, should be a very well kind of status. Eventually, the country is also very serious to run a national One Health Mission program. And we were talking on the breakfast table exactly how it should really go. And also, country is very serious, and the seriousness is the institute which has almost come up with all kind of facilities. She was talking to me that, do we have a assembly facility over here? And we were just conversing with that. So keeping it short over here, because we would like to hear from both the stalwarts who have gathered the area of One Health through the topics which they are going to cover. And I am personally, on my own behalf and on behalf of NI against, put it on record, a word of gesture of acknowledgement and thanks to both the speakers to come over here and make this day more important. And when such talks comes, surely they are befitting to the theme with which we celebrate One Health. Wishing everyone good wishes for this One Health Day. Thank you very much.
Thank you, madam. So now I welcome Dr. Jitendra Pal Singh Gill, sir. He is a distinguished academician and an eminent researcher. He joined the Vice Chancellor of Gadwasu very recently on 11th September 2024. He has been associated with Gadwasu since very long, almost like 29 years, and has given back to the university with several research initiatives and research collaborations across the globe. And he has authored over 240 research publications and over 4 national policy papers to his credit. And he has guided more than 22 postgraduate students. And not only that, he is also a member of several international committees. For example, I'll just name a few. The list was running, but I'll just name a few which I found very interesting. Joint FAO WHO expert meetings on foodborne antimicrobial resistance, AMR, National Standing Committee of Zoonosis at NCDC, as well as he is a member of the scientific panel of FSSAI for the biological hazards since 2020 and also antibiotic residues since 2018. Not only that, he is also an expert in the development of national action plans on AMR in India, which has been sponsored by WHO. And he has received several prestigious accolades. I'll just name a few because the list was again running a lot. This is like, for example, T. Sherkar Outstanding Public Health Veterinary Award, as well as the V.S. Alwar Memorial Award, just to name a few. He is also the Fellow of National Academy of Veterinary Sciences and also the President of Indian Association of Veterinary Public Health Specialists. Today, he'll be delivering a lecture titled From Policy to Practice, Implementing One Health for Integrated Health Solutions in India. I warmly welcome you, sir, to the dais.
इसी पे कॉपी कर दो Okay. Thank you, Madhu, for the nice words. Respected Director NIV, Dr. Tav Sharma ji, Dr. Pragya ji, and my dear scientists. I am here to give a talk on One Health. Yesterday, 2 days back, when I received the topics of ma'am, so there was little similarity in the program, the talk. So I changed little one, giving more emphasis to the One Health, and the initiatives of the government will be mainly covered by Dr. Tav Sharma, and I am giving my own experiences. So on the One Health. So I am working in this field for the last 20 years. In each and every meeting of One Health, when I go there, I got a little confused. Everybody is working on most of the time, just like this picture of the elephant. जो उसको देखता है वो उसी को उसी तरह का करने की कोशिश कर रहा है. So that's why I am here to what is the One Health, who promote One Health. Just brief about my institute first, just a few minutes. Guru Angad Dev Veterinary and Animal Sciences University was established in 2005. It was the earlier part of one of the topmost university, Punjab Agriculture University. So in the 15 years, last 20 years, it has become one of the top ranking veterinary and animal sciences university. We have about 6 colleges, 2 colleges of veterinary sciences, 1 dairy sciences, 1 fishery sciences, biotechnology, and 1 animal biotechnology, and 1 center of One Health, and 2 colleges for the diploma, and 1 that's the diploma pharmacist, veterinary pharmacist, and we have 4 research center outside our universities for the research and training scientists to disseminate knowledge, and 4 Krishi Vigyan Kendras, in which the technology we develop are disseminated to the farmers. Student strength is about 3,000, and the staff strength is around 300. So this is a brief about my institute. So what's the history of One Health? It's very long history, around 460 BC. The first time notice was that the Pope Clement XI gave an order to his physician, Lancisi, to work on Rinderpest. Rinderpest was the devastating disease. Mainly, it was not worried about the animals. It was worried that it is a human food supply is affecting. So he was given the order, and he recommended first time that they kill all the diseased and suspected animals. And the principle was the milestone in controlling the spread of the contagious disease in the animal. The major work was done by the Rudolf, a German physician. He said that but between animal and human being medicine, there is no dividing line, nor should be. These are the few scientists which worked and demonstrated the links between the animal and human kingdom: Hippocrates, Jenner, Pasteur, Koch, and Calvin Schwabe and Steele. They are the major work in the One Health. If you go over the milestones, in the 18th century, it was first what was done on the cowpox, that the cowpox inoculation protect the human from smallpox. In 19th century, there were zoonotic diseases were identified, that was anthrax and rabies. In 20th century, first time the integrated health centers of the CDC was established, and veterinary public health. So One Health was earlier known as majorly in the international forms as the veterinary public health, and they have one idea that one medicine and one ecosystem. In 21st century, one world and one health. SARS, MERS, swine flu, influenza, these are the major outbreak come. In 21st century, analog holistic health paradigm, mainly the planetary health ecosystem, One Health initiative and One Health mission was established. And recently in 2022, One Health high level panel of the experts were followed. That's the quadruplet work done. So why One Health is important to address local, regional, national, and global health issues with healthy environment, healthy animals, and healthy human beings. And One Health approach is collaborative, multi-sectoral, and transdisciplinary. The main idea is that triple C: collaborate, coordinate, and communicate. So just take comparison. If we have a general health approach, suppose in that we have to tackle the AMR, they will work on tackling the AMR in the drug for the drugs in the hospital, whereas the veterinarian will work on the antimicrobial use on the livestock. Whereas in One Health, AMR is tackled by limiting the animal drug use, environmental contamination, accounting for socio-ecological and cultural determinants. Second example is poor, very good example, the poor mental health of the shepherds attributed to the low income. That the medical people say. The veterinarians say that the low income attributed to the high mortality among livestock. This is mainly in the New Zealand and Australia. But if we work on the One Health, the problem comes that the poor mental health attribute to the high rate of livestock deaths and the loss of the livelihood. If there is livelihood loss, the death of the animal, the mental health will deteriorate. That's the other thing. Finally, we come with the One Health high-level expert panel. So it is established in 2021. Earlier, it was tripartite agreement in which UNEP is not the part. The aim is to give the guidance and input the enhanced cross-sector collaboration with agreement on the mainstream One Health approach. So they have the 4 focus areas. First is the One Health implementation. Second is inventory of current knowledge and preventing emerging zoonosis. Third is the surveillance, early detection, rapid data sharing. And fourth is the factor causing spillover. This is the main theory on which now all the groups are working on. So they give the first definition of the last definition that now is of One Health. One Health is the integrated, unified approach that aims to sustainably balance and optimize health of people, animal, and ecosystem. It recognizes health of human, domestic, and wild animals, plants, and wider environment that are closely interlinked. So they break all the professional silos, social scientists, leaders, all they comes in the one umbrella. That's the One Health program. So they made in 22 to 2026, they made a one action plan. Most of the countries are working on this action plan, whether they have One Health mission or anything. But the main idea is this One Health joint action plan, in which besides giving the few ideas, the one is the good idea was the traditional knowledge and indigenous people and local communities using their knowledge. That was they are in each of the country, they are giving more emphasis there because the indigenous peoples are more close to the environment, more close to the animal, and they have the policies which are interlinked with the animal, human, and environment. So they have the 6 action plan. First is enhancing One Health capacity to strengthen health system. Second is reducing emerging and re-emerging genetic epidemics. Third is controlling neglected and eliminating the genetic diseases, means the vector-borne. Fourth is strengthen assessment and management. Fifth is curbing the silent pandemic of AMR. And finally, integrated with the environment. So on the basis of this is a very complex thing. This is a Cosmos model, which is shows each and every linkage. If we see that ecosystem, human, animals, in ecosystem, all the things which are contributing that the climate change, pollution, contaminant, biodiversity. Then in the human system, everything, the wild animals, livestock, companion animals, then their health, human health, vaccination, epidemiology, veterinary medicine, and their global health. All these things they have made a model, and we need to collaborate with each and every person in this model if you want to work on the One Health. That's why I say that everybody is thinking, if I'm working on this aspect, One Health is only this. If I'm working on environment, he's considered One Health is only this thing. But we have to collaborate and integrate all the things. So One Health priority areas, the One Health committee that make the 5 major areas focus area. First is emerging and zoonotic disease and pandemic. Mainly they work on the avian influenza. Then their second topic was neglected zoonotic disease. That are brucellosis, tuberculosis, schistosomiasis, and trypanosomiasis, food safety hazards, antimicrobial resistance, and environment and health. All the programs now running in world are basically all these 5 programs. Some are taking 1 or 2 programs, others are taking all the programs. So I will cover a few slides of all the 4 or 5 programs. The emerging zoonotic and epidemics. You know that 75% emerging diseases are infectious and zoonotic, and 60% are spread from the animals. This is the timeline of the outbreaks. First, in 14th century, plague, then smallpox, then cholera, then 20th century Spanish flu, Asian flu, Hong Kong flu, and HIV. And this is the main area, the 21st century, when we have all the outbreaks are there. If you go for this, you have the BSC in 1990, then Hendra, Nipah virus, Marburg, SARS, that Streptococcus suis, H5N1, H1N1, Ebola, Zika, MERS, and COVID. So this is in the last, I say, 20 years we have these outbreaks, and now the re-emerging is the monkeypox these days. I used to say that for the veterinarians, the 2 diseases, the avian influenza and COVID, are blessing in disguise. The veterinary public health people or the veterinarians comes in the picture to then now the actual One Health is working on all the platforms that they call for the veterinarians for the meetings. So it is a blessing in disguise. All the time, the topmost magazine, they have the 8 cover pages on SARS, bird flu, avian flu, Zika virus, H1N1, then new diseases, the coronavirus. So all the media is also working on this. What's the major thing? The COVID is not only the worst zoonotic disease, but it is worst, but it is not the first. In the last century, there are the 6 outbreaks of the coronaviruses, novel coronaviruses. In our last 2 decades, before the COVID, zoonotic disease caused economic losses of about $100 billion US. Tragically, 2 million people of low-income group and the middle-income group from the neglect are suffering from neglected zoonotic disease such as anthrax, bovine tuberculosis, and rabies. Nobody is these days working on basically on these major problems. These are often communities which with complex development problems, high dependence on the livestock, and proximity to the wildlife. If we used to see the losses, it is not on the loss to the animal industry or the human. If you see that in the Nipah virus, there is loss to the swine industry, then to the business closures, then the re-employment, all the industries are affected, and it is about $550 million loss. If we go for the H1N1, there is about 45 to 55 billion loss, and it was lost mainly in the travel, tourism, and the port industry. In the Marburg disease, that loss is into the mining industry. And whereas the Rift Valley fever, there is loss to the livestock, the threat to the food and livelihood of the farmers. These are the major losses. If you go for the avian influenza, there is a loss of $20 billion. In antimicrobial resistance, it was estimated that about $100 trillion will be lost and 10 million annual deaths will be there. SARS, 41 billion loss. In East Coast fever, about 200 million loss, and that last is the very major figure that are neglected zoonosis. It is a loss of 2.5 billion and cases and 2.5 million deaths annually. This is the major things that comes in why the government is working on these aspects. So when we go for the funding from any agencies for these diseases, just when we work on the brucellosis, everybody, just like in the major funding agency, they didn't know what's the impact of this disease. So we first decided in my institute to work on what is the economical losses of the major diseases. when we showed that this is the economic loss of this disease, we got the first project on the DBT funded major network on zoonosis. So in the livestock, the economic losses is 2.5 billion loss, and in Punjab it was 662 crore loss. It is mainly from the cattle, sheep, and goat. The losses are mentioned. So if we go for the human beings, it is the 627 million loss in the human beings from the because we, as per as our estimate, the about 15 to 20% veterinarians or the field workers are suffering from brucellosis, and there is more of loss of the morbidity. From assisted gynecosis, there is the 11.47 billion loss in India. From neurocystic cirrhosis in the human, there is 12.3 billion losses. These are the, we collaborate with the topmost epidemiologists from Australia, Dr. Tan, who was our student, my student. So we worked with them on the epidemiological part, and we calculated these losses. From the porcine cystic cirrhosis, there is 1,064 million losses, and average we say that per pig there is the loss of ₹100. So this data we make the if you see the all the policy paper, there is the data of these zoonotic diseases, and this is the basic reference for getting the funding from the major agencies. So the major factors why the epidemics are there, mainly the deforestation, rising food and water demand. There is intensification of agriculture and the livestock industry, population growth, loss of diversity is also a major factor for the zoonotic disease, climate change, and globalization. These are the high risk of the agents of factors. If we see what's the major factor influencing the emergence of the disease in last 20 years, and what the factors in 2007 are changed in 2017, and models say that they will be changed. Mainly the three factors, that the international travel and commerce, the climate change, economic development and land use and poverty, and the human demographic and behavior, they will be changing in last, again in 10 years, rest will be remain the same. So we need to work on these changes. So there is another WHO warning that we should go for the preparation of the next disease, the disease X. So the government of India and all the governments are making their preparation for the next pandemic so that we should not be caught just like in the COVID. So I will give you the one example how the various factors or drivers work on the spread of one disease. I have to give the example of avian influenza. If you see that the consumption of the poultry has increased very, very much. Although the meat consumption has increasing from last few years, but the poultry consumption has maximum increase in the poultry consumption. And if we see that how the human growth, there is rise in the human growth, there is socio-economic improvement, high demand of the animals protein source, then there is increase in intensification of poultry production, which is vulnerable to the avian influenza, genotypically similar concentration. Then intensification, again, there was there was intensification of agriculture and land use change, which lead to the climate change and the loss of the wildlife habitat, then change in the wildlife migration patterns. Then there is increased frequency of avian influenza outbreaks. Then there is risk of the spill of that. A few cases of avian influenza are coming these days, and the culling stock and disinfection, delaying the restocking, this is economical loss, and there is undermining food and nutrition security. So these are the major factors. The other topic I'm little covering is the antimicrobial resistance. Everybody knows it well. So it is a silent pandemic. It is thought that projected that by 2050, 10 million deaths will be annual there in the world, and there will be loss of 300 billion to more than 3.4 trillion annually by 2050. That's why everybody is now working on this. And the major gains comes to the animal sources, food of animal sources, mainly because they are contributing to the availability of cheap animal sourced food, used as growth promoter, poor animal welfare condition lead to the more antibiotics, lack of access of the pathogens, specific antimicrobial and lack of other antimicrobial things. This is the model prepared by von Schwab, this model, in which he predicted that in next few years, the 4 countries, mainly the Brazil, Russia, India, and China and South Africa, will be the highest consumer of antibiotics in the livestock. We invited von Beckel to our institute for one of the lectures. We discussed about this model, how he predicted India as a major contributor to the AMR. He calculated all the things on the basis of the body mass of all the animals. We have the major part of the livestock, buffalo, cattle, and the antibiotics are mainly used in poultry and little in the piggery as a growth promoter. But he considered all the biomass as one and divided what they found in the US, European Union, each small country, that if the biomass is this will be the antibiotic use. If our biomass is very high, and he predicted it. And this model is shown everywhere that India will be the major contributor to the antibiotic resistance in the livestock. But we should always in all the platforms should say that this is the wrong model that I am depicted, because we only use the antibiotics as a growth promoter in poultry and to very small extent in the piggery, and no growth promoter is used in the large animals, because in the large animals only the beef producer use the growth promoter. So, but we still are blamed on basis of this topic in each and every platform of AMR. Simple thing is that livestock industry, veterinarians are responsible for this all things. We should contest this type of things. So the other bigger problem is the environment. You know that the antimicrobial pollution from pharmaceutical production, agriculture runoff, livestock manure, and human waste goes to the one of the reasons for the antibiotic resistance in environment. Exposes wide range of microorganisms to the antimicrobial genetic material, increasing likelihood of the AMR. I will discuss on this thing. So how we can manage in the as a One Health approach to tackle the core problem of excessive and non-specific use, access to the public health, food security and ecosystem, decision-making process, and action across the all temporal and geographical scale. So I used to give this picture how we are blamed in the media that each and everything that pharmaceutical, that the animal husbandry is the responsible for the AMR. We have some conceptual idea how the AMR has spread to the environment by the, if we see that from feed, it goes to the human, and there is the poor infection prevention control measures, lack of surveillance system, then the selective pressure and the resistance. And from this, the in farm animals, it goes to the environment, manure environment. 10 to 14 billion bacteria goes in the in the manure by daily, and they are causing the transfer of the. If we use any antibiotic, about 50 to 60% of the antibiotic as such come to the feces or the urine in the animal, and they are quite good responsible for the antibiotic resistance in the manure. Manure is becoming one of the major source of antibiotic resistance and spreading the antibiotic resistance to the environment and the saprophytic bacteria. So, because we are blamed everywhere, we don't have any data. What is the antibiotic used in the? We did a survey all India throughout the India in my institute. We sent the on the mail, on the WhatsApp groups. From the we asked for the veterinarian, para-veterinarian, and quacks who use antibiotics. The thing comes in the picture was that the veterinarians are the most responsible to the less least responsible for the antibiotic use, but the quacks, class 4, and farmers themselves are the major user of the antibiotics. So all our awareness programs, we focus only these two. We didn't focus anything on farmer, class 4 and quacks, which are the major user of the antibiotics. So why they use the antibiotics? Maximum antibiotics are used in the mastitis, reproductive disorders, hemoptysis disease, diarrhea, and these are the least infection where they use the antibiotics. So we should go for if we go for the other type of the treatment, given the stress of the vaccination and the herbal drugs, we should mainly focus on the use of in these three type of the diseases or the classification for the stopping the antibiotic resistance. So then we ask, who recommend the antibiotics to you? There was a very strange answer we got. Mainly they say that we give by own experience, availability of antibiotics in that area. We did one survey in the Himachal Pradesh, antibiotic residues and availability of the chemist shop near to him. Further, we go to the heights where the antibiotic, their chemist shop is away and the veterinary hospital is far away. The use of antibiotic residue was very less. So the availability of only the antibiotic residues that were available on that shop was the major residues. Then the cost of antibiotic and the recommendation from the other veterinarians, positive culture and sensitivity test, which should be the major thing, but this is not used. And they are using what type of the antibiotic, which are the highly critical, high priority critical antibiotics by WHO. Veterinarians are still using these type of the antibiotics. The two things that from all the major studies, 3 or 4 studies we have done, comes that why the antibiotic is used, that's the illegitimate demands by the farmer. If the veterinarian or para-veterinarian goes to the farmer that and give a one injection or no injection, they say that veterinarian doesn't know anything. If they give 3 to 4 injections, they are very satisfied. So the farmer, that's the demand of the farmer to give them injections. Second is farmer non-cooperation to the completion of the course. 5 दिन का course है, 1 दिन टीका लगाएंगे, 2 दिन 3 दिन नहीं लगाएंगे. That is the major source of resistance. Then farmer aspiring the antibiotic directly from the acquiring from pharmacy. The biggest problem is now these days that the medical representative directly go to the big farmers. They put their medicine in them to them for the sale, and they are the big farmer sell the medicine to the small farmers. There is no middleman. Directly company is selling to the farmer. That is the major thing which we observed in our studies. Similarly, the antibiotic resistance, which I have already discussed, we found that the antibiotic resistance genes are maximum in the slurry. So resistance, we can say that resistance anywhere is a resistance everywhere. If we don't work on it, either in the livestock or in the environment or in the human beings, we are suffering. The final sufferer will be the human being. So we need to have a one health approach to work on all the environment, human health and animal health. Food safety hazards. Every year, foodborne disease cause almost 1 of the 10 human beings to ill. 33 million healthy lives lost. And among them, the children are the maximum losers. That is 4 lakh, about 42 lakhs deaths, and 1 out of the 3 kids suffer from this disease, the foodborne disease. So, if we see what is the major cause of the foodborne disease, the things I have mentioned in the red, these are the majority the animal products. Whether it's a milk, meat, eggs, pork, the fishery products, these are one of the major source of the foodborne illness, and foodborne disease cost about 28 billion rupees and around 0.5% of the gross domestic product every year in India. This is the data of the World Bank. So we need to also work on this aspect. The major reason is that the demand of the food and animal meat is increasing. In last few years, from 21 years, there is 54% product increase in production of the grains and 53% increase in the meat consumption throughout the world. That's so if we are going for the meat and crop production more, then we have to intensify our agriculture system, and that lead to the more diseases. So there is by 2050 there is 70% increase of the demand of the milk, milk 30%, meat 70%, eggs 80%, mainly due to the population growth, economic growth, and urbanization. So another, so this is the slide not clear, I think. Major things I want to tell is that we have the increased demand, but the losses of the food, spoilage or other loss, is maximum in the Asian countries. That's about 20% of our food is lost. So in the overall world level, it is 10 to 15% loss is there, but in Asian countries, especially in India, Southeast Asian countries, there is a 20% whatever we produce is lost due to the spoilage or other things or non-consumption. So on one way, we are intensifying our agricultural livestock production to increase more food. And on the other side, the more spoilage is coming on, so we need to work on this thing. So how this food systems and the pathogens emergence coming? We work on the high requirement of the food system. If we see that the for the population growth, technology capacity, there is increased agriculture intensification and habitat alteration that lead to the opportunist habitat expansion and ecological release, mainly the vectors, wildlife, feral reservoirs, and human encroachment is there. And there is changes in the host pathogen dynamics, mainly the host switching, breaching the pathogen persistence, transmission amplification, and genetic exchange. That all these things directly related to the more food production and disease emergence. So if we need more food, produce more food, will be the more emergence of the new diseases. I will give you the one example of burger. One burger produced by suppose it's a Burger King. It needs major 4 chains. That's the crop, spices, milk products, and the meat products. And the global chain of one burger for one producer is the 200, about 200 vendors. From 200 vendors, the products are received to produce one burger. So we need not to go for the hygienic quality at the shop, how the burger is prepared. But that chain, we need to work on all the 200 vendors which are supplying the material to one product. So it is a very complex change. We need to work on each and every thing that if we want to work on the food safety systems. Then comes the environment and health, mainly the water and food supply, changes in the vector ecology, allergens, severe weather condition, air pollution is the major cause of this condition. This one slide. This is the shows that how one Aedes mosquito in how many months in a year they can spread the disease. If we go and seeing that 2019, the more the pollution is coming, that in the area where the Aedes spread the disease in 1 month, start spreading the disease in 8 to 9 months per year, so they can spread the disease. In the Arctic regions where the temperature is very low, they doesn't spread the disease, but these days they are spreading the disease in a very high way in those countries where it was not earlier. So, will not work. So this is the global emissions. What's the role of the livestock industry in this? So 31% directly from livestock and fishery, the global emission is there. Then about 6% from the animal feed, which in the crop is there. Then again, the land use for the livestock 24%. So the major role of the livestock industry and the crop industry is there in the global warming and the global gases. If we need more food, we spoil more food, then we have to intensify our farming, and there will be the more effect on the environment. So the greenhouse gases from the has increased in last few years by 10% from the dairy farming, from the agriculture, and 14% in last 20 years from the greenhouse gases emissions from the livestock industry. So the pesticide use, it is increased 36%. There's a major problem in our food safety issues that may lead to the inappropriate exposure to the agriculture worker, exposure to the food consumer, loss of invertebrate, loss of fish, mammal, birds, plant diversity, and impact on the aquatic species. So we worked on in our institute on these pesticides. But the good thing is that I have done my PhD on pesticide in 1999 and 2000. At that time, all the food, milk and milk products were contaminated with the pesticides, and about 20 to 30% were above permissible limit. We keep on continuing the studies of the pesticide residues. Mainly the two types of the residues that are organophilies. They are drastically decreasing in our food, but their half-life is more than 20 years. But still they are coming, but they are in the very, very less quantity. So there the reduction of the DDT is from 20% to none. Linden, that's 80% to none. Androsulfone 6%, it has decreased to the none. And the chlorpyrifos to none. That's the maximum permissible limit. So there are residues in our food, but they are below the permissible limits. Similarly, the antibiotic residues in our milk, we found the 2% oxytetracycline, 3% enrofloxacin, 5% oxytetracycline, and above the permissible limits by one method or other. So what's the benefit of this One Health program? If we implement the One Health programs, then there is response to the health issues, events, and emergencies timely and effective. Decisions are based on accurate and shared assessment. Regulation policies and guidance will be realistic. All sectors understand the specific roles and responsibility, and the gaps of infrastructure are identified and filled. I will give you the one example for these benefits. So this is our ecosystem. We have the wildlife, we have the human beings and domestic animals. Wildlife in green, dark green, domestic in the light green. If there is an outbreak comes in the wildlife of one disease, there is an outbreak, increased number of the cases. These are the normal cases. Earlier were the normal cases. This is the one outbreak is coming. Then it goes spread to that disease spread to the monkeys and the chimpanzees. That directly spread disease to the amplifying factor to the domestic animals. And when it goes to the domestic animals, then the increase of incidence of disease in the human beings. Mainly due to the spillover from the wild animal, spillover from the wild animal to the domestic, spillover from domestic animals to the human beings. But if this is a present case, that the first case start in the human beings, then we go for detection, the cases rises, then the lab confirmation, another rise, then the response, another rise. But the ideal thing is that within few cases, we should work on the outbreaks, and the outbreak cases will be decreased. So to prevent, we need the wildlife surveillance forecasting, we need the early detection methods, then we have to need the control opportunities. If we go for that, we work on the spillover from animals to the human beings, spillover from wild animal to the human amplification, spillover from wildlife to the human beings, then we can again decrease the incidence. So this is the One Health approach, that we have to work on the wildlife, environment, vectors, and the human health for the thing. The another thing is the good thing that now these are predicting. We have also done this, that we can use the human animals as sentinel for the human disease. So if we can found that the PDBE, that's the perfluoroalkyl substances, that they are used commonly in the households. if their cats are suffering from that disease, the children are, after a few months, children start suffering from that disease. Similarly, we develop a model, how can we detect the brucellosis as a human as sentinel? ਅਸੀਂ ਪਿੰਡਾਂ ਦੇ ਵਿੱਚ ਗਏ, ਅਸੀਂ ਸਭ ਤੋਂ ਪਿੰਡ ਦੇ ਵਿੱਚ ਜਾ ਕੇ ਵੈਟਨੇਰੀਅਨ ਤੇ ਪੈਰਾਵੈਟਨੇਰੀਅਨ ਦਾ ਬਲੱਡ ਟੈਸਟ ਕੀਤਾ। ਜੇ ਉਹ ਬਰੂਸੈਲੋਸਿਸ ਪੋਜ਼ਿਟਿਵ ਸੀ ਤਾਂ ਅਸੀਂ ਫਾਰਮ ਦੇ ਉਹਦੇ ਵਰਕਰ ਦਾ ਜਿਹੜੇ ਫਾਰਮਰ ਦਾ ਚੈੱਕ ਕੀਤਾ, ਜਿਹੜਾ ਫਾਰਮ ਵਰਕਰ ਪੋਜ਼ਿਟਿਵ ਸੀ ਉਹਦੇ ਐਨੀਮਲ ਵੀ ਪੋਜ਼ਿਟਿਵ ਸੀ। So taking the blood from the animals and the large number of the animals is difficult. If we check the veterinarian or paraveterinarian, if they are positive for brucellosis, then there are the chances that the farmers are positive. So there is one success story, the rabies vaccination in Chad. When the Chadian Minister of Health talked about that a mass vaccination of dog to eliminate the human rabies, he replied that he was responsible for the people, not for the dog. Asked about the same issue from the Minister of Animal Production, replied that his priority is cattle, not dog. Economical analysis demonstrated that cost of doing mass vaccination in dog and human treatment is less than the human treatment alone. Because vaccination in dog can interrupt the transmission of cycle. Here the One Health approach can give the better outcome of the human and well-being. So similar, we are working with duopology. There was one program on the rabies control program. They are working only in the human beings. They prepare the pamphlets, they go for the vaccinations. They are doing public awareness. If the bite is there, we should do this, do this. I just said that you are doing the wrong thing. You need to work on the dog. ਜੇ ਡੌਗ ਚ ਰੇਬੀਜ਼ ਵੈਕਸੀਨ ਹੋ ਜਾਵੇ ਤੇ ਡੌਗ ਬਾਈਟ ਹੀ ਵੈਕਸੀਨ ਬਾਈਟ ਤੇ ਰੇਬੀਜ਼ ਹੋਵੇ ਨਾ ਤਾਂ ਆਪਾਂ ਹਿਊਮਨ ਦੇ ਵਿੱਚ ਕੰਮ ਕਰਨ ਦੀ ਲੋੜ ਨਹੀਂ। So we need to find the exact reason where we have to interrupt the transmission cycle. If we were working on the dog, ABC program are out more and the vaccination is good in the dog, there will be the no rabies cases. Around 30,000 deaths are reported by the WHO per year in the India due to the rabies. That can be decreased. So very brief about the One Health approaches, because as far as the one of the modeling, the India, especially the Gangetic region, is considered as one of the four hotspot of the new emerging diseases, that the zoonotic disease in the India. So we have adopted the tripyrate program, WHO, FAO, and OI, and now the coordinated program, we have adopted it. But we need to strengthen the framework of the One Health. Ministry of Health and Family Welfare is working on rabies control, zoonosis prevention program, leptospora program, and field epidemiology program. The ICMR is also working on the zoonotic spillover detection study. So this is the National One Health Mission. I'm not going in detail for this. So in the just one thing, in the National One Health Mission, all the ministries, ICR, state governments, National Disaster Management, NCDC, Family Welfare, Environment, ICMR, then Animal Husbandry, Pharmaceutical, DBT, all agencies are working in one mission, and they have the one goal. Ministry of Science and Technology, DBT, that ma'am has talked about that. They have the one, we have started One Health Consortium program, and it is a very successful program. Ministry of Animal Husbandry, they have also started the One Health program, One Health Support Unit in the Ministry of Animal Welfare. They have started in the two states. One is Uttarakhand and Karnataka, with the expected outcomes of efficient disease reporting system, optimal utilization of lab resources, capability of handling zoonotic organisms, emergency preparedness and awareness program. So ICR has started the All India network of work on One Health approach of zoonotic disease. Networks project on livestock and poultry product safety, Farmers First program, and the inclusion of One Health in their curriculum in the agriculture and the veterinary sciences. National action plan of the antimicrobial resistance has been initiated, and it has been working on implement legal framework and zoonotic spillover detection that has been initiated. Ministry of Health has started the integrated health information program for 2033 diseases. Government of India has in the G20 the idea One Health, Earth, One Family, One Future, and they have started the National Institute of One Health Nagpur, on which the madam is the director. So if we see the One Health research in India, in the world, if we go by that in India, if we go the study cases, the dark blue is the least one. If we go for white, the green or yellow, these are the maximum one. So India has started working on that from last 20 years on the case studies, but still corresponding authors we are doing good in this. But the national, international collaboration, still we are lacking very much in the One Health study. This is the India case, the darkest one. We are still the lowest, that's the one ranking. So the how we can principles necessary to implement One Health approach. It is the paradigm shift, system thinking, multi-sectoral, interdisciplinary response, and socio-political or multicultural parity. This is the challenges in implementation of One Health. This is the model how we can implement the One Health programs. It starts from policies and funding, then education and training, surveillance, multi-sector collaborations, then evidence producing. So there is need of a multi-domain collaborations, multi-level collaborations, then we can work on these are principles. But the challenge is the starting. So to start this, we need funding, education and training. But if we want to execute it, there is need of surveillance, fragmented and capacity building, collaborations, monitoring, and multi-institution collaborations. So if we go for the point-wise siloed system, traditional separation of human, animal, and veterinary sector, although we are sitting together, still there is difference. We are doing our work in silos. Ineffective communication, collaboration, missed opportunity for integrated surveillance, resource limitation, funding gaps, structural issues, and the staff storage. Insufficient education. We have limited inclusion of One Health concept in the medical, veterinary, and environmental curricula. We need to go for the capacity building, regulatory, and the policy gaps required, and cultural and social factors. These are the major challenges. So we have had the missed opportunity till date. We have 706 medical colleges and 56 veterinary colleges in India, but still there is no coordination between it. All the major programs started by the various ministries, they have not incorporated many of the resources, capacities, lab capacities within these institutes, which we are developing the new capacities, new infrastructure, but we need to use these medical colleges and these veterinary colleges and about 26 veterinary institutes, which can work on, go for the help in this thing. India's subcontinent is the hotspot of zoonotic and drug diseases and vector-borne pathogens. Still, we are not working on these hotspots. We are working in other areas. Still, the hotspot is, we are not working on it. So only the ICMR is working on the J infection in the genetic region. Government structure and inter-sectoral coordination is also problematic. Most of the agencies are launching new programs independently, in no coordination with other, and treating One Health is only. Most of the time, DBT doesn't know what the ICR programs are there. ICMR is not knowing what the animal inventory is doing. So the National Health Mission, so I talked to Dr. Sundur about this in one of the meeting. First meeting should be that let's have the knowledge, one brainstorming of all the programs going on, all the successes, all the failures. If we have done a DBT program, ma'am has very good experience. What are the good points? What are our failures? What diseases to be included? What diseases need not to be included? And if the ICMR again starting the same program and including the same diseases which we consider that they should not be included in that program, the feedback should be taken. Similarly, the DADF, I have no criticism culture. They adopted Uttarakhand due to some reasons for One Health program. So the major area in which the major livestock is there, major outbreaks, border area, that should be selected if they have a One Health program cast out there. But due to their own wishes or political reasons or some other reasons, so they go on selecting their own institutes If I am coordinator, I will go for NAIB, I will go for the Kanwas, I will go call madam. But it should be an open invitation, open challenges, call for that we are launching this program. And the institute will has the capacity, capability should come together and work together. Sorry for criticism.
Perfect.
So the reason embedding the collaborative holistic approach, One Health approach society will be equipped with well to deal the complex multidisciplinary disciplines. This contrasts with the siloed approach, which may be capable of addressing complex system issues, or we do not have fact may only address one of the social outcomes, neglecting the others with a single sector gain, but overall losses of the wider society. So I will take 5 minutes to show what we are doing. So in my institute, we have established first the School of Public Health and Diagnosis, which is one of the 18 departments in the Veterinary Institute, one of the Veterinary Public Health department, from which I am coming. So we started School of Public Health and Diagnosis, which was later converted to the Center of One Health. So in that, there are the only 8 or 9 members in that. So we are collaborating with national or internationally with almost 30, 40 institutes internationally and with the active projects with each of them. So in 2011, we first started the Collaborative Research and Training Program. That's the NSARC Canada funding. That was 4.2 million funding. That One Health integrated training on infectious disease, public health and food safety. For industry, public sector, academia, ensuring safe food, integrating science and health in policies, global network, Canada, Germany, and India. There were 117 applications, out of which 17 were shortlisted, and we are selected for that. So the major institutes were Free University Berlin, Gervasu, and University of Saskatchewan. There were the courses, research project, and summer schools. Later on, University of Sao Paulo also joined us in this project. So we had the industries with the Canadian Food Inspection Agency, Public Health Agency of Canada, Agriculture and the Agri Industry Canada. Government, we built the policies and the governance in 2012 at that time on the One Health. So we first of all thing that we discussed about how to prioritize the disease. So we start working on the assessing and prioritizing zoonotic disease in Punjab and India in the One Health approach. So we worked on the various parameters, and we worked on that brucellosis, rabies, and anthrax, leptospora are the major diseases which we need to give emphasis on the more funding. So we worked on the brucellosis. The One Health approach we started working on brucellosis, and all the medical colleges, PGI and AIMS we gave the lecture in them. We make aware their doctors about the brucellosis incidence. The samples start coming for us for detection. In my hospital, I have tested more than 20,000 human samples of brucellosis. Good thing is that 15 to 18% bacterial or parabacterial or farmers were suffering from that, and they got treated in our medical college. They were given treatment, and completely they were regulated their treatment, and they were fine until the zero prevalence level comes at 0. And we worked with on the control programs. We worked many control programs, and the development of evidence-based brucellosis control program in our institute, and that we gave to the government of India before the implementation of the program. That's the things we worked in the brucellosis program in my institute in One Health. Then on antibiotic resistance, that's the slide I've shown. The CAT studies and the quantitative studies on the antimicrobial use we have worked on. And then the monitoring of the antimicrobial uses in the adult bovines analysis and what is the pattern and frequency. Then on aflatoxin toxins, we have worked on the exposure and assessment and risk of the aflatoxin M1 through the consumption of the milk, occurrence of the M1 in the bovine milk associated with the dairy farms. Then on the One Health in the COVID, I'm proud to say that Gervasu worked on the at the start of the COVID. Gervasu was given a responsibility to start the COVID testing labs in Punjab. We gave all the instruments to the 3 medical colleges, and 20 scientists went there to train their medical pattern, just like One Health. So for 2 months they worked there. Then we started our own COVID lab at Garbasu by Government of India, and we tested about 7 lakh samples with a frequency of 3,000 samples per day. And we are given the ICMR and UNICEF award for a thorough output lab for 1 crore equipments, because all of our samples were samples which were given for the testing, 5% samples were accurate at that time. So in that time, we worked on the meta-analysis of the COVID-19 disability and the state life. So we worked with the Canadian institutes because their scientists are free. They have published very good articles on the air quality. So we worked on the One Health activities at the intersectoral coordination at the local levels in India. Then one thing, very complex model. For antibiotic risk, the one thing is the biosecurity of our farms. If we see the antimicrobial uses, these are solid lines are the positive interaction. If we are the farmer is education is good, the use is less. So similarly, the model was there. And finally, we found that if the antimicrobial uses are to be decreased at a dairy farm or a poultry farm, we need to strengthen our biosecurity. And then we check the biosecurity parameter of all the major farms of the north. The score is 100, highest we got is 50. And majority are below the 30. So we started the one postgraduate diploma in One Health. It is an online course. Anybody can join it. Only 5 days or 6 days. You have to go there at Garbasu for examinations. Online classes are there. So till date, veterinarians, medical professionals, dentists, veterinary academicians, wildlife, and NGO professionals are enrolled. And it is a very successful program we are running online, in which international faculty is giving the lecture. So we have a One Health literature on all the aspects. Enhancing the AMR, we have the booklets, and we have one app that for the AMR. We go for the field-oriented application on the One Health, avian influenza outbreak, LSD outbreaks, environmental protection, FMD biosecurity, awareness in the villages. Recently, new programs in the center is the Zoonosis Control Committee of Punjab for improving. It's mainly the ADB funding, Asian Development Bank's funding with the Sadhguru project. Then the NCDC sector. This is the FAO project to develop mainly the preparedness of the pandemics. Then the joint proposal to strengthen One Health framework with the help of the regional zoonosis diagnostic lab. So if for the future, we need for the collaboration, surveillance and data sharing, laboratory service centralization, disease prioritization of the research, education and training, community engagement and public awareness, environment, health and policy sector. So the key message change in food system have brought benefits, but also the massive challenges. Food systems are complex with hunger and negative impact on many different outcomes, hunger, climate, ecology, and disease, and a complex causal mechanism. Addressing these challenges, therefore, require holistic approach capable of managing these diverse causes and outcomes. One Health approach offers a way of doing this in order to better protect the human beings, animals, and environment. What we say, we must do and apply. Do de-siloing to One Health holistic approach. And knowing is not enough. Everybody knows what to do, but we must apply. Wishing is not enough. We must do. So I acknowledge various agencies for preparation of these slides. Thank you. And I thanks my team of One Health. There are a few persons there from the One Health. Thank you. Tell me, I'll take some more time. Okay, any question?
So I thank sir for this infectious talk, and we really benefited a lot. Now I would like to introduce Dr. Pragya Yadav.
Member, please.
So it is my great pleasure to introduce Dr. Pragya Yadav, a scientist whose research is on communicable diseases and highly pathogenic viruses has had a transformative impact on public health. Born in Uttar Pradesh, Dr. Yadav has built an exceptional career grounded in her deep commitment to public health and infectious disease research. As a senior scientist at ICMR NIV Pune, she has led excellent work on dangerous viral infections, including Crimean Congo hemorrhagic fever, Nipah, and Ebola. Her expertise has shaped critical improvements in India's public health surveillance and intervention policies, establishing her as a leader not just in India but on a global stage. Among her great contributions, Dr. Yadav led the development of Covaxin, which is India's first indigenous COVID-19 vaccine, and she was very instrumental in identifying India's initial COVID-19 cases. Her vision and expertise were also essential in setting up NIV's BSL-4 laboratory. With more than 200 research publications, Dr. Pragya is widely respected in the scientific community and serves on numerous global advisory councils, including the WHO Zero Expert Group on Nipah virus. Madam was also selected as a fellow of the Centers for Disease Control and Prevention USA, Japan International Cooperation Agency, and the National Academy of Agricultural Sciences, India. Her notable achievements have been recognized through various awards by India's Ministry of Culture, ICMR, and Ministry of Health and Family Welfare. This year, Dr. Pragya also received highly prestigious Rashtriya Vigyan Yuva Puraskar in the area of medicine. And with this, I am extremely fortunate, and we all are fortunate to have Dr. Pragya with us today to share her invaluable insights. And please join me in welcoming Dr. Pragya.
Thank you, Sonu, for such exhausting biodata you're reading. First, I would like to thank Dr. Taru Sharma. And I'm so glad to visit this institute in her leadership, which I'm sure are doing a wonderful work. With a small team, I'm sure you are going to be reaching the heights. And she has a lot of good plans which will be executed, and the institute will remember forever her excellent work. Being a woman leadership, I respect more her to reaching to this place, and I wish further success to this institute. Can somebody help me to move the slides, please? Little bit uneducated with the very sophisticated system. So thank you. So you can see this one. Yeah, and this one is good. Okay, thank you. So this is the BSL-4 facility which you have seen sometime in media, and this is the BSL-4, how we work in our BSL-4 facility. As we are celebrating International One Health Day, so I send my congratulations to entire team of NIAB. And as Dr. Gill has emphasized, a very elaborate on not only One Health, but also what India should look forward. Just quickly, though he has summarized a lot, but quickly, if I look at the history of pandemic, which you all know, and recently one we have gone through COVID pandemic. There were many, and most of them either bacterial. Plague was the one of the disease which caused most of the pandemic, pox viruses, and then most favorite one is causing pandemic is influenza viruses, which caused most of the larger pandemics. And in 2009, we have seen one of the pandemic, and everybody predicted the next pandemic will be influenza virus. But for a surprisingly, the COVID came as a pandemic. If you remember in 2001, and there was an emergence of COVID virus, which we call SARS coronavirus that time, which started from Hong Kong and lead to 10,000 deaths. Not only that, if we look at if we compare the different death which was caused during the pandemic, there was some pandemic even which wiped out the 50% of the populations. So everybody talked post-pandemic COVID with a lot of enthusiastic about pandemic preparedness, disease X, but as a habitual, we forget very slowly when the situation becomes calm and we go to the routine diseases. But I just remind you that 21st century is a century of emerging diseases and especially viral diseases. And that's why everybody is emphasizing to strengthen the capacity not only in the India but globally. If we talk about the scenario of India, there are many diseases which are not only genetic diseases, but they are also having capacity to cause pandemic or maybe get mutation and spread from India to many other continent. So for few examples, Nipah virus, you must have heard, Dr. Gill gave example also, but in India is present in 2 states, human cases has happened. Similarly, Crimean Congo hemorrhagic fever, which is again a high risk pathogen. And then monkeypox is also being reported from India. But as we know that no diseases are now supposed to be in particular boundary. They can be people can travel and diseases can import from one place to another. This is a picture of last month where you can see that every country is reporting daily so many outbreaks, and which means that virus, bacteria, and many other diseases, they are reality of today. We cannot anymore ignore them thinking that this is somebody else's problem. If we look at the kind of travel we have, the number of flights are roaming from one place to another, the diseases will not stop to one place. During the COVID, if you remember, during the lockdown, even during the lockdown, in 2 months, any variant of concern which emerged in any part of the world. Remember when it started with the Alpha variant from London, it slowly reached to all over the world. When the Delta variant emerged in India, it reached to all over the world, in spite of the international lockdown and all the precautionary measures which people were taking. This, in fact, give a very loud message that diseases understand no boundary. Recently, there was a study done by Predict where they collected the specimen from 60 countries and they found more than 1 lakh of the different infectious diseases, and we don't know which one can lead to other new pandemic or any outbreak in which part of the country. If you remember the COVID pandemic, the kind of impact which posed on the livelihood, human health, governance, social system, and economic system, and there was a race of making diagnostic vaccine, and many countries actually felt very short when it came to implement and fight with the COVID pandemic because of the lack of infrastructure, medical infrastructure, and so on. So the list is very, very big. And in this race, India was a major player because today we have the 1/5 of the global community we hold. So it means the population is so big. If we don't address these issues, we won't be able to survive in future. If you look at the history of SARS coronavirus in December, when China started reporting the cases, India was just waking up, preparing for the testing. And that was the time India was even not making primers pro. Forget about other reagents. Mostly we import all the reagents, all the testing kits, each equipment which you use, and we using a lot of equipment, and you just put their fingers and you realize coming from Germany, US. So we have very less manufacturing of all these material which is required to fight such kind of pandemic. At the end, so the first struggle was to develop a test which we did very quickly because of the very good practice on infectious diseases. And we roll out with 13 laboratory of VRDL system, which is already exist in country. And we could detect the first 3 cases from Kerala through the VRDL confirm at NIV, sequence in 24 hours. And that was very fast actually. In fact, when we did not detect earlier 3 cases, people blame India. We are hiding cases. We have detected, but we are not declaring. And after those 3 cases, we could not see any more cases, though all the international travelers were getting screened, they were getting sequenced, but we have then cases in March. India was further blamed that we are not doing enough testing, that's why we are missing cases. So there are a lot of game of blame on India because of our wide population, kind of people who are stranded in different countries. There were a lot more challenges which we ever thought which can happen in a pandemic. We always work in India and in a reactive mode. When the outbreak will happen, we rush to the site, we do the containment, we do the testing, and then we leave people to die or live. So that was a very, very different a scenario which we could see in pandemic that we need to do better than this. And there were many response. And the India's first response, as soon as we realized the Italian tourist came to India and the cases spread to Jaipur and Delhi, was to do a very quick lockdown in on 24th March, and that was the first country's lockdown where we could see such kind of situation. It was not easy to accept, but India went in a very long time lockdown, and then it was extended. When PM announced it, people got standard at many places within the country and outside the country, and that lead to a new kind of response. But we must appreciate the first time in the history, I think, all ministries, all the private partners, everybody felt a responsibility to work together. And I think that is a one of history in India's after the freedom, where everybody thought to contribute to pandemic, either is a private partner, government power. Those people who could not do anything in the COVID, they try to do social support system to the hungry people. And in many ways, I think that that kind of responsibility which came to everybody's shoulder was amazing, and that we could see slowly. But there was many challenges which was related to pandemic response. The first was due to lockdown, we need to improve the efficiency of technology. Early diagnosis and detection was the major challenge. The next point came for the genomic surveillance as soon as the variant of concern started booming up, and we didn't have many genomic facilities across the country. But if we look at 4 years back and now, we can see India is a better country now for in all the sense. The next question was the healthcare facility. Not in the first wave, but you all remember in the second wave when the Delta happened, what was the situation? We didn't have place to put the patient in the hospital. But this was not only condition in the India. If you remember, China faced the same. Even Europe faced the same. And a country like US faced the same kind of situation where they claim that they are prepared for a pandemic, they have better infrastructure, but nobody was actually in reality ready to deal with such kind of pandemic. Then there was many other challenges with the critical partners, private sectors, and then we didn't have enough. Not only the manufacturing, but supply was also sabotaged for the PPE equipments and reagents, and there was a huge challenge to bring all these things. The war started from zero to start preparing the test, then establish the laboratory training virtually because that time we could not travel. Then shipping the RT-PCR reagents, and NIV could become a hub of not only the storing but also supplying reagents across the country. Then we started working. In most of the influenza viruses, people don't believe on serological tests. But for the COVID, we have to reactivate to develop the serological test. Then there was a challenge. Then there were private partners came up. They said we want to make these reagents. We need to validate. So all kind of new channel need to be established for the validation, for the testing, for the approval from CDSO. And DCGI has shown extremely well capacity during this pandemic, which was not possible. Another factor which I would like to bring as a research organization, in past, if you want to do any preclinical study, it takes years. If I want to do an HP study, it will take 5 years. That was the written kind of rule. And we have done some of the study where it took 5 years with the intervention of ministerial, and so many people came in the picture. Then only we could do it. So there was a lot of challenges within the system, and people thought we cannot fast track. But we learned that we have to fast track, and we learn new methods. Then there was another we did a lot of repurpose. For example, sewerage water testing, which we always use for the polio virus surveillance. If you the polio is under is called GAP4 program, and India is having essential facility in NIB Pune, where we don't have any wild kind of polio circulation in India, and constantly we are doing sewage water testing. This was repurposed for COVID. Genomic surveillance was strengthened. Then we started different kind of programs across the sectors, including the antiviral testing, isolation of variants, and so on. So the list is so huge, and we evolved with the challenges of the COVID. But there were many other factors. We initiated many COVID laboratory, and there was a biosafety challenges, risk assessment, laboratory biosecurity. Then we also need to work on medical diagnosis, environmental safety, and so on. As Dr. Gill has mentioned earlier, that to enhance the laboratory to scale and test Indian population, we started from one laboratory from NIV, and now we have 3,300 laboratory across the country. And out of that, 165 are VRDL, which can test every single day 28 virological pathogen. But now, this development has enhanced our capacity across the sector, because when I say 3,300 laboratory, it includes all the government, private sectors, and everyone come in the picture. And not only that, we could also become the biggest manufacturing hub for the vaccine, which can not only produce for our country, but also we supply to 145 country under the vaccine mastery program. These are the some of the success stories, and government of India work on different approaches to leverage these programs. The first, do the R&D, product development, large clinical trials, in-country supplies and global supplies that included Covaxin and Zyco DNA vaccine. But at the same time, we also work on technology transfer, bridging studies, augment production, and that could lead to making many vaccine in India, producing a huge number of the products, Covishield, Gemcovax, Covax, Corbevax, Sputnik, and so on. So currently in India, we have all kind of vaccine platform which we can use for R&D and also for the production. And this did not happen overnight. There were a lot of efforts from DBT, BIREC, ICMR, DCGI, and so many other support from government to address so many challenges which came during this vaccine production, that included funding, clinical studies, laboratory study, epidemiological, advanced purchase orders, at-risk manufacturing were supported by government, raw material imports, and so on. So a pandemic preparedness takes more than what we actually thought in the past, and that include a large number of pictures. If I give some of examples in India where we have presented this One Health approach in a better way, and there are some examples I can give. The Nipah is one of the example, which was the first outbreak happened in 2001, where 48 people died in hospital, and 5 years we could not even identify the disease. People keep searching fishes and so many things to identify what was the cause of those deaths. And it took 5 years to send the sample to CDC and then confirm Nipah as a disease. Because in India, we didn't have any containment facility, we didn't have any diagnostic assay to do so. We could establish the first BSL-3 in an IV in 2005, and we started testing the high-risk group of pathogen. In 2007, when the next outbreak happened in Nadia, we could immediately identify that it is a Nipah disease. Not only that, in 2018, when the Nipah outbreak happened, in that gap, we were searching all the bats in West Bengal to identify the hotspot for Nipah disease. But surprisingly, the outbreak happened in Kerala. And this was a bigger outbreak where 21 cases happened and 18 people died in that outbreak. But after that, we have constantly worked with the state government and also central team. Further, we are not seeing such bigger outbreak, no further death, which you can see with the number in 2019, only one case, no further death, except in 2021, during the pandemic, Nipah outbreak happened, where everybody is sneezing, coughing, and you don't know who is having COVID positivity, who is having Nipah positivity. Still, people were isolated, people were taken care, and no further transmission happened. And actually, that shows how India is slowly working in preparedness mode, and we are doing better detection, we are doing better containment, and we are progressing toward a better One Health approach. Quickly, if I give example, this year also, we have 2 isolated cases and no further transmission happened. Though Nipah is a deadly disease, so whenever index case get infected, there is a very high chance they will die, unless until they are identified at very early phase. They are given some antiviral or monoclonals to save them. There were many more challenges when the Nipah outbreak happened in Kerala. People were not ready to touch the bodies of dead people. And it took time to train the healthcare worker, make them aware how to do isolation. Even we didn't know how to do that in a hospital setting. So these are the large number of challenges which we faced. And when the pandemic happened, do you think we were ready? No, we were not ready. We learned by a very, very tough time. But Nipah outbreak, year and year, taught that we cannot work in silos. We cannot do just testing. We have to work with the entire One Health approach, engage everyone to understand how the transmission is happening, who all are getting infected, what are the seasonality of the virus, and how we can save the situation. So this is one of the example which I would like to bring to the kind attention of this. And we have actually reported each and every event which happened in Nipah to speak scientifically that what happened every year. Not only that, we work on infrastructure, and we could make this mobile BSL-3, which can be deployed during the outbreak setting, and the samples can be tested in Kerala or in any state of the country using BSL-3 facility. We also did extensive study with the bats population to understand the seasonality. And now we know that from April to September will be a high season, where if you come in the close contact with the bats, you will have a possibility of Nipah infections. So, but we also realize that we cannot be biased with one or two states, so we need to do a bigger study. The second thing which I learned through the genomic surveillance, the sequence of Nipah which is circulating in Kerala is different than Bangladesh or in the West Bengal. So genomic surveillance is the one of very important factor when we talk about the surveillance. And when we did surveillance in multiple species, we also found not only Pteropus, but also Raucetus bats are having a possibility of getting infected with Nipah. Antibody was found positivity. Further, we expanded this surveillance across the country, and we could see hotspot in many states where we could see Nipah viral RNA and IgG positivity in many states, more than we thought in the past. So we have to be open toward the research. And this is another example of a strategic intervention for a Nipah disease prevention, where we are still working on monoclonal therapy and vaccine, but how we can use One Health approach to early diagnosis and saving human life. The second disease which I would like to bring to this kind audience, that CCH virus, as I mentioned, that slaughterhouse can be used as a, we started this slaughterhouse in 2010, and we found that a sample which collected from 3 states, the Rajasthan was showing antibody for CCH positivity. Very quickly, we enhanced the hospital-based surveillance, and the first outbreak was confirmed in 2011 January, where 6 people died in Gujarat. And this was just a beginning. We were suspecting for many years, but because of the lack of the reagents, lack of the strategy and laboratory, we could not do it. As soon as we started, we could see cases every day, every year. And in 13, 15, and 19, there was larger number of cases, not only in Rajasthan, but also in Gujarat. And we also observed the importation of the CCHF cases from Saudi Arabia and other places. And this was only possible if you increase your surveillance. Your laboratories are sitting, and as soon as the suspected cases come to you, you will able to detect. Many times, because of the similar kind of clinical patterns, they can be confusing. In 2015, when the outbreak happened in Rajasthan, Gujarat, and Delhi, cases was reported from 3 places. There was a lot of hype of media that Ebola has entered to India, because that time Ebola outbreak was going on, which affected 30,000 people at that time. But finally, it confirmed to the CCHF, which started from the Goel Hospital, Rajasthan, and cases were spread to many places. We also detected many other cases. We have done a very thorough surveillance. We developed diagnostic assay, and we could prove that these 2 states are endemic for CCHF. The ticks are positive. We also did a countrywide livestock survey, and we found up to 50% seropositivity can be seen even in cattle and sheep and goats. So these are some of the challenges where we cannot do a study alone. And we use the FMD network to get the samples and test them. And this will actually give a holistic view of a CCHF seropositivity in the animal. So if we go on another latest example, if I give, that is a monkeypox. Smallpox, we all know that was one of the human disease which was eradicated due to vaccination, and people always thought that monkeypox will be next threat, which was true actually. The disease which was always restricted to South African 7 countries suddenly during pandemic started spreading, and it was declared as an international health emergency. From 2022, we have 35 active laboratory across the country there, where they can not only test the monkeypox, but they can also test buffalo pox or any kind of referral pox sample. For differential sampling, we also enhance the capacity for varicella zoster virus, herpes, and other similar kind of pictures where the cases present. So far, India has reported total 33 cases, and one of the case is latest Clade 1B, which is reported. When we talk about the capacity enhancement, that how fast we can test, how fast we can isolate the cases so that it cannot lead to the community transmission. In this process, we also detected many varicella zoster, enteroviruses, and buffalo pox viruses from different part of the country. Not so far, the Kerala and New Delhi, these are the two states where they have reported cases, and we have only one death case reported from Kerala with a young person who traveled and was positive from UAE. So if we look at most all the cases of Kerala are imported cases. In Delhi, we have community transmission in Nigerian community, and these are the recent 3 cases after the second declaration of international health emergency of one Clade 1B, and we could quickly sequence and confirm the Clade 1B cases, Clade 2B cases, and also Clade 2 further C lineage. In the past, if we talk about prior pandemic, these are the diseases which considered to be priority diseases. But with the lesson learned from COVID that we cannot be biased, there was a big exercise done by WHO where they have 300 scientists they have selected from each country, and I was part of Bunia family, where they sat together on a very complex structure to prioritize the diseases from each family. So out of 25 family, each family has one representation, and diagnosis, vaccines, R&D should be done, and then each product should be ready for each family, and that should be taken forward. You can go through this document available on the web page for the details. Then there was a major challenge that how we can strategize our action to prevent and detect biothreats. And there are many factors to it. We have to strengthen not only the biosafety, but also biosecurity. We have to have the integrated capability to prevent risk assessment, biosurveillance. We also need to have the ability for forecasting. So if we talk about the way we did all the outbreak and pandemic in the past, it was more mainly through the reactive approach. But we have learned that we need to have the capacity to forecast and prevent epidemic for the future need. And the One Health is a measure. It was existing for ages, but COVID has actually highlighted the need to work together, because we cannot work in our individual capacity as in silos. That will not solve the problem. The one thing which very important, which I would like to highlight, whenever there is outbreak, especially if it is a high risk group of pathogen where death is very high and there is no treatment, the challenge would be how fast you can identify. If you can identify fast, you can do the isolation and you can stop the community transmission, and that will be a success of the public health system if we achieve to that. But in the peace time, we also need to prevent, anticipate, and prepare, detect, and we have to constantly work on that, because many analysis came out after the pandemic which demonstrated that the cost of response is 6 times higher than cost of preparation. So preparation would be best way to do that. We also learn by bad experiences that biothreat not only can be naturally, but they can also be deliberate release of bioterrorism, and biowarfare can happen, and we need to increase the capacity. In that line, to leverage on infrastructure, which was developed during the COVID pandemic, we are working on improving surveillance, early detections, and also the counter measure, intersectoral collaboration and coordination. And these are the few examples which I am presenting from ICMR side, but the similar kind of efforts are done through the ICR, CSIR, DBT, and each sector of government, where every sector was asked to enhance on the infrastructure that include enhancing the BSL-3 laboratory, next generation sequencing sites, molecular testing sites, and PM Abhim have launched 4 new NIV-like structure across the country, and also Nation Institute for One Health. Nation Institute of One Health, as Dr. Gill was mentioning in the morning, it was initially thought to be satellite center for NIV, but after the pandemic, it was modified to be a National Institute for One Health, and which was launched in 2022. We are in a process to making this institute, and the plan is to work together. All 13 ministry and each state health department has to collaborate and work in a way that we should navigate the country's response in the future. In this process, there are two committees has been already formulated. The first is executive committee, which is chaired by Honorable Minister of Health and Family Welfare, and PSA is the vice chair, and the second is scientific steering committee, which is chaired by PSA. And the first meeting of executive committee happened in September, and there are some very important decision has been taken, which will be slowly implemented. Scientific steering committee is also now working on verticals, how we can do the data integration, how we can enhance our outbreak response, and how we can work together. It should not be silos and isolated efforts with different sectors, which has been a practice in the past. There are certain objective of National One Health Mission, which is being which will be soon launched in the summer, that is, I assume. And the main objective of this mission is to undertake integrated and holistic R&D across human, animal, plants, and environmental sector, establish framework of integrated disease surveillance, develop roadmap for targeted R&D for fast-tracking medical countermeasures, coordinate research, data, and information system, create a cadre of trained professionals for R&D, joint outbreak response, integrated surveillance, and also to foster linkage with global efforts for pandemic preparedness, such as many international agencies. So in this line, there was a lot of efforts to understand that how we can improve our surveillance across the country. And there were, after a lot of efforts, some of the plans has been come up in the place. So model surveillance project at the animal human interface would be the first priority, the wastewater surveillance, syndromic surveillance for infectious disease, and strengthening capacity for indigenous production of diagnostic. As Dr. Gill has presented, that One Health Joint Action Plan action was given by WHO and many 3 other international agencies, where they define that what should be the 6 main track of the action. And if you read these actions, out of 6, 4 are linked to the emerging infectious diseases. So somehow, because they are linked to the not only the human health but also animal health, so we have to focus on those preparedness. The first project, which is recently launched, is the launch after analyzing that what kind of syndromic surveillance we require in the country, and that is, I'm just going to name quickly: acute encephalitis, myocarditis, conjunctivitis, and hepatitis, respiratory illness, acute fever, and acute diarrhea. These are the 7 syndromic surveillance we require in the country to understand. And if you want to know that from where we are having emergence of pathogens, which may be undetected because we didn't have any surveillance system in the past, or we have a patchy, small efforts done by individually team group members. But we need to learn more. We need to have a model which can be implemented across the country. And in that process, the first slaughterhouse surveillance program is being launched recently, which covered 3 states, including Punjab, Telangana, Assam, and many other institute and laboratory are engaged to do the testing. These projects were made after a lot of discussion and understanding that what diseases should be tested, what kind of sample to be collected, what should be our SOPs for each testing. And the main purpose is to detect, diagnose illness among slaughterhouse workers. They will work as a model to understand what diseases they are getting it. And this is the launch pictures. Dr. Gill is part of this study. And through this launch only we came to know each other very closely. And we have under this study, 11 slaughterhouses are being selected, and that they will serve for the poultry, pigs, sheep, goat, and buffalo samples. Initially, they will be tested by PCR and ELISA and antigen testing, but all the undiagnosed samples would be taken for NGS, and we don't know what will be the outcome, but this is just a beginning, and I think we require a lot of input. So if you have any ideas and if you want to discuss, if you want to do something, please come forward. We can always tweak these protocols, studies, because we are in a learning phase. The next project, which is the to model for respiratory virus surveillance in bird sanctuary, because we all know the respiratory pathogens are the one who are always the highest priority for any pandemic or outbreak pathogens. In this, the sanctuaries will be targeted where the people who work in a very close contact with the birds are will be samples, and based on the predictions will be done. Again, the many centers has been taken in these laboratories, including Sikkim, Bhopal, Nagpur, Pune, Gujarat, Baramati, and then many laboratories are also roping in this facility. And also for the data mining, we have taken few centers who are expert, and especially NIH Chennai is good expertise in mining the data and collecting them. So this is the second study which you can see in the picture. The centers have been chosen based on the kind of bird sanctuary they are close by, and the related centers who can support this activity are also pooled across across the country. The next study is acute encephalitis syndrome, and many medical colleges has been selected where hospitalized cases or reporting cases should be selected. They will be tested, and undiagnosed cases will be taken for a genomic surveillance to understand. Though we have already decided the list of pathogen in each project which will be tested, but NGS would come up with the more finding what we are missing, and they are not part of our algorithm. If you have noted that recently we have reported avian influenza cases in West Bengal, and also in many parts of the country, the avian influenza outbreak was reported majorly this year, and that actually not only enhanced the need of the pan-India syndromic surveillance, which was started with the 27 sites, but now we have 73 sites which report weekly the data. And if you're interested, you can go to an ICMR webpage and look at the data which influenza virus is surveillance circulating, and all those unidentified samples will be taken for the NGS. And to enhance this surveillance more optimally, we also included NIFA in the West Bengal and Kerala. And we will do the testing of all the negative samples. And if that take any lead, then we can further enhance these surveillance across the country. Then there was another need which we felt during the country. We require low cost multiplex molecular diagnosis for syndromic surveillance of infectious diseases. Because if you talk to laboratory, they will tell that they don't know which kit to buy, which reagents to be purchased. So in to address that syndromic surveillance, prioritization of pathogens study was also done, and we have prioritized pathogen which is important for India, and drafting standard assay protocols, sensitization of industry partners. Many meetings were done, and promoting them to manufacture these kits in-house. Recently, 3 monkeypox PCR kit has been launched, which will be produced by in India for the India, and which the cost will be very less. Similarly, efforts are being done for many other pathogens, and I'm sure with the efforts and with the help with the DCGI, we will able to have this dream coming true, that we should have all the diagnostic manufactured in India, but with the quality system, which is the most important for any diagnostic. Further, there was more efforts to through the MedTech Mitra, the medical device testing lab with the CDSCO has been established. Validations protocol has been addressed, and the most important, the bio banking repository of clinical sample and strains for license optimization and validation of indigenous assays are also being in the place now and continuously under the improvement. Laboratory under One Health, National One Health Mission, as NIH is still under the preparedness, but we are not waiting for it to come. We started the activity, and now we have 22 BSL-3 laboratory network, which is going to work under the NOHM for One Health activities. And we had a multiple training started in April in NIV, where we did BSL-3 training to understand what is need to improve these laboratory, how we can have similar kind of SOPs and protocol. Then there was a training at Nishad Bhopal for handling animal and environmental sampling. There was a huge gaps. People say that if we are testing human sample, we can't do animal, and if we are doing animal, then we can't do human. So this gap need to be filled. That if you are in lab, you should be able to test all kind of sample, and that is the first challenge to resolve. And to resolve that, we created this assessment tool for BSL-3 laboratory, which is we implemented in human sector, and also we are developing in the form of a this is a very good tool where you can take this tool to any laboratory stat, and you just ask the question, fill it, and you will know what are the gaps, and you can address those gaps. And we make and you can score each gaps, and based on that you can even categorize those laboratories. So this tool was used for categorize many VRDL facility, which is under this program. Then there was a question that what SOPs we use, because every lab has different SOPs. So we try to harmonize the SOP, and the SOPs was asked from each sectors, harmonize, and then now it is available on the portal, which you can browse, you can use, and you can read, and you can utilize in your SOPs. There was another steps which was taken by with the initiative of Dr. Rajiv Bahl, where we did the country's first national mock drill on is called Vishanu Abhyas, where we went to Ajmer, a very remote area, and we did a simulation of respiratory pathogen outbreak, deaths, and clustering of the cases. And then we asked the team to respond from different sectors. And this was not just hanky-panky mock drill. It was a very serious drill, monitored by DGHS, DG at a daily basis. There was a meeting, briefing, and then it was observed by National Security Council and many other very serious people. Everybody made their own report, and there were 3 debriefing to understand what we lack in our system, where we need to improve. And this debriefing has been communicated to each sector to improve on this outbreak response. Another point which I would like to be a part of international community, whatever we detect, it is not our own business. We have to report to international through the NCDC, we report to IHR, and it goes to WHO, and a lot of international decisions are based on these kind of reporting. We have to constantly report to international. I would like to quickly summarize the lessons and the messages which was given through the G20, where we have loudly said that we need to strengthen the BWC to achieve sustainable development goals, and the most important, we have to not only broaden and strengthen the participation of developing countries in the institution of global governance. There was a recommendation which was very important, carried by SEG to multiple responsibility, and that was the last line which I would like to ask you to read through. The responsibility for ensuring compliance and reporting non-compliances, training program courses on ethics, material management practices, personal protections, and safe disposal practices to prepare every country for future pandemics. And as a global community, India, nobody could be better than India, where we have Mool Mantra, Vasudev Kutumbakam. Our philosophy is always to work together, think about everybody's well-being, and that is what the One Health, which I would like to quickly summarize. And there are many requirements which we learned through the pandemic, and Government of India through the different programs, through all the government sectors are trying to implement. And the one is the first and most important national strategy to combat weapon of mass destruction, increase funding for all the vaccine, biosurveillance, mass casualty care, public health and medical preparedness, and a framework for biodefense. So these are my key messages at the end. And with this, I thank you once again. Thank you very much. If there is any question, I'll be glad to answer.
Thank you, ma'am, for the informative lecture. that communicated the need of National Institute of National One Health Mission in preventing and eradicating the present as well as the future diseases. Thank you so much, ma'am. We can take questions. The questions can be for both the speakers, please. If there are any questions, please.
Pragya, wonderful talk. I was more interested in the Nipah virus outbreak, information which generally as a public we get to know from the media. So is there any portal or anything, the ICMR portal or anything where all the information regarding how the disease, happened, what was the source, how it spread, what happened, how did they figure out that this is the, pathogen which is involved? Is there any website where we can gather those kind of information rather than looking at media and then get confused all over?
So one thing about the NIFA, the media which report is very right, because all the information is given by Health Minister Kerala. So that's the one thing I can assure you. The report which comes during the every outbreak is coming through the Health Minister single source, and that's why ICMR don't speak when the outbreak happened, because we all know that the health is a subject of state. So the state take lead in speaking, giving information. And one risk communication is one of the very important lesson which we did, because during pandemic we learned that infodemics is very, very crucial. Bad happen, people get confused, and there is a lot of anomaly. So one point source messages coming from the health minister, which transmitted through the media. But all the information of the Nipah outbreak we have published. So if you just search Nipah, and you will get all the information of each outbreak. The purpose of the publication of each outbreak to give these lessons to everybody, that how you can learn from these outbreaks and do the better. So I give another in 2019. I just give example. We didn't have any mobile BSL-3, and Kerala government said we cannot send samples outside, and so our team went there. In a BSL-2 laboratory, they set up a testing lab, and then with the BSL-3 practices, they did all the testing, and they trained almost 30,000 healthcare workers. So and then initially we trained some, and then there was trainers to the trainers start training to rest of the people, and the awareness program was initiated by state government. So there's a lot of good point which we can learn from NIFA, from Kerala state government, how they act during the outbreak, and how we don't interfere in that action. So that is another lesson. But I would like to mention here, because you asked a very relevant question, that the National One Health Vision has come up with the idea of having a joint outbreak response team, which is a national joint outbreak response team. So now in future, whenever there will be outbreak, the representation will be there from each sector. It will be, every sector will be there, so there will be no misunderstanding that what everybody is doing, and or whatever it come as a consolidated report, and which actually we practiced during this 24 outbreak, where the team included every stakeholders. So that is a main thing which we have to implement years and years, and during every outbreaks. This year, if you have seen the reports of other outbreaks, I give example, Chandipura outbreak in Gujarat, multiple people speaking, so much confusion, and that actually lead to much of the anxiety in the people who are going to Gujarat, who are visiting with the children. They don't know what to do, because the message is so confused, and message is coming from so many people. So I think risk communication is also very important during the outbreak, and which we need to learn by Kayla. I must tell that. Thank you.
Thank you. I have another question for Professor Gill, if I may. Sir, I see that you are part of the AMR action plan team. So I remember in 2014, probably the Schedule H drugs got implemented, and some of the antibiotics are over there. But if we think AMR is a big issue, that it can create next pandemic, why not have all the antibiotics under Schedule H? Why and why not? What are the difficulties in getting them implemented, or what are the problems that the public might face?
This matter was discussed. This matter was discussed very in detail. There was one question that do we have a very good infrastructure throughout the country in villages where there is no doctor in kilometers away? So that's why they didn't put all the antibiotics. It was discussed that it was initially a part that these should be done. But because I was working on the livestock part, we are the member, but this matter was discussed because the question was raised at that time. We didn't have enough infrastructure in many areas that all the drugs should be on the prescription only.
Sometimes we can.
That was the out of the back of the stage story. It was considered.
Mhm.
There was question that we should ban or should we all be drugs should item, but still they think that we need something. The paraclinician, the persons should give the patients where there is no facility available for the doctors in 20 kilometers, 30 kilometers, 40 kilometers. There is no doctor available. Who will prescribe the drug?
So if you see in the US, there are certain people who are authorized to prescribe, not only the doctors, Pharm D, something like that could
Something
be
we know.
implemented.
The wrong is done. But we can't put everything. If we put as well as practice, all the scheduled drugs are available on the counter.
Yeah.
If we put them on all the scheduled drugs, but still its availability on the counter is there. First, we put some in that and put restrictions. If we are able to put restrictions, रूल बनाना बहुत आसान होता है, रूल को इम्प्लीमेंटेशन करना बहुत मुश्किल है. पहले उतना कि रूल बनाओ, मैं चाहता हूँ कि जितना हम इम्प्लीमेंट कर सकें. बड़ा बना लेंगे तो इम्प्लीमेंट नहीं किया तो उसका फायदा.
Wonderful answer, sir. One more question for you. You are sitting in high-level meetings where they discuss about One Health and the implementation that keeps happening. So majority of the people talk about infectious diseases, zoonotic pathogens, but what about food animal diseases, which are not directly causing disease or infection in human, but affect the food, just like crop diseases also.
So
as well.
that's the main thing is the food safety.
Yes.
Not the food. The food safety is the main issue. If we just like say the one slide, if we need the more food, we will put more fertilizers. If we put more fertilizers, they will go for the water eutrophication will occur. The next production will be the crops will have less protein, more carbohydrates. So this type of the things are considered in the One Health program.
And how about funding opportunities for those compared to zoonotic pathogens? Is it equally done or
The
not?
question is that we have to prioritize everything. So we can't put money in all holes. So we have to need to work on what are our 5 priorities. From the environment point, soil, water becomes the first priority. Then comes these things. But in the disease conditions also, I used to say that we need to prioritize the disease. We need to have that, just like if the ICMR is working, was the part of in the Jaipur and the Odisha, they have done the One Health. What are the priority zoonotic diseases? They have worked with the WHO and FAO for this. So we prioritize 10 diseases in which we should go for 5. Everything for the lab, everything infrastructure should be there, and 5 in the upcoming time. If we get more fund, then we work on these 5. So for the One Health in India. So just like a food safety and food security. I was in one of the meeting of the FAO. The person was asking for the decreasing the limits of aflatoxin, decreasing the limits of this and this. I used to be very vocal. I say that there are the 2 things, food safety and food security. If we have enough security, then we'll go for the safety. So if we have the in India, if some food is destroyed, that is consumption consumed by the other low strata. If that is not eatable, it is given to the livestock. No, usually not wasted properly. So we have to prioritize the things. If we have enough food security, we will go for the food safety.
So Dr. Madhuri's second question. So Professor Gill very correctly mentioned in your slides that directly the antibiotics are given to paravets or directly by companies and also. So your question, so last year, December, DHD has put one Nandini app.
Yeah.
And they said for the whole country, all the livestock thing, everyone has to go through this app. So on 20th, there was a meeting chaired by PSA. So I was talking to Animal Husbandry Commissioner. I was asking, so Nandini app is almost a year old. So what I concur what Professor Gill said, so things are at place, actually execution. So is the Nandini, I mean, it's not a, the good part is the app is at place. Alone DHD cannot just do it. So that also is one very important thing, like talking to people. And as you rightly mentioned, so he also answered the same. So we have made it mandatory, but it is taking its own time. So I believe, and also what Dr. Pragya was saying that Nipah virus. So Nipah virus, yeah, I mean, Nipah virus is the moment we talk about it's not only the medical fraternity, it's I mean, the Nishat's a bigger role and stuff like that. So those points also come into the concern is what my personal feeling. Thank you.
I will give you the one more example about the not being a One Health persons in all the meeting. I was in the FSS panels on antibiotics residues. There was one doctor who read one article of a person, only one or two, one article in which they have given a treatment in experimental for the tuberculosis. Streptomycin, they give and they found it. He has read that article and he was very influential person. In that meeting, he made a recommendation that use of streptomycin should be banned in the animals. And in the next meeting, he came with a list of 156 medicine, which are in which the many are the basics medicines which are commonly used, routinely used in the animals. They said that they should be banned. And unfortunately, uska draft banke nikal gaya. So I was that panel, I have to contest it very hard. So that list was down to the 33 antibiotics. And because we are in the Food Safety Authority of India, we can say that its tolerance in a residue should be 0. But we are not authorized to ban it. But they have used that platform to ban it. So at One Health program, if the person is a veterinarian, I am a veterinarian, I need to know what the. So I made a right to all the veterinary hospitals, private practitioners, deans to write against that draft. If we are not aware about our rights, our things, what are going on. So in the next 15 days, that draft will be a bill, should have been a bill. So कुछ बार हमें भी देखना पड़ता है भी दिस एंटीबायोटिक अगर हम स्ट्रेप्टोमाइसिन को भी हम कर देंगे भी QLH में या बैन कर देंगे then what medicine the E. coli is the E. coli whether it is in a human being or in an animal the drug will be the same.
Thank you.
Yeah, one question here. Thank you both speakers for the wonderful talks. My question is to Dr. Pragya. So regarding the Nipah outbreak, so we keep hearing all the time, but as you rightly said, they don't spread. So what do you think is preventing their spread every time they are reported?
I'm not saying they don't spread, they will spread. I'm saying the efforts which has been made in years and years and the lesson which we learn has helped to detect at the first index case itself and isolate the case or the burial is done properly and isolate all the high risk population till the incubation period is over. So nowadays, if there is any case detected, most of the time when the index case reached detected, they die because it's a very deadly disease. And if it delay a bit, people can die. But if you can at least isolate all the high risk population, maybe family members, doctors, nurses who came in the contact, you can make sure that further no transmission happen. So I give example of 2023. So after 2018, there was a lot that year, a lot of chaos was there, but we learned. And then we implemented all the practices which is required in the hospital. how we can make the containment zone, how we can stop. So most of the time schools are closed, and all the cases are identified who have been come close to the patient or in anyhow in the close contact. Late in 2023, there was a one case which had admitted in hospital. Then there was a nurse and everybody got in contact. So there was a family contact where that include a very small child. There were 12-year child, and then the nursing person's family got also infected. So there was total 6 cases, but out of the 6 cases, two of them died. So most of the time, next cases are having very high viremia. They are detected late. They are not being taken care of. Sometimes they move so they have fever, mild fever. So they go to take some local care. Then they will have some severe illness. Then they will go to next hospital, next. So it actually they travel to many hospital. And in the process, actually in the first outbreak, it happened. Like the patient admitted to many hospitals. And that's why many people died. But now, because of the awareness, if somebody come only with the fever or with the fever with AES or fever with ARDS, they should be immediately tested for DFA. So that strategy was implemented that help actually immediately testing them. Not only that, TrueNet PCR which we develop for the DFA, it is available in the hospital. They can test all suspected cases. So in case if anywhere patient is moving, so if any case turn to be positive, immediately they can isolate the patient. So that actually awareness and early detection, all these efforts make happen to be not spreading the disease down. But one more point which I would like to mention here, Nipah can be presented in two forms. It can as presented as acute encephalitis syndrome. So based on our experience, if it is presented as AES, the transmission will not happen. But if it is presented in the case of respiratory infection where patient is sneezing, coughing, so then the transmission will be very high. So then maybe more people get infected, which happened in 2018, 2023 as well. So how the cases are presented also matter, and how much they are coming in the contact with the people, and if the people are following any PP, all these actually everything together matters.
Yeah. These diagnostic tests, are they available in private hospitals too right now, or are they are only in some of the centers?
Hospitals are not authorized because then so any such notifiable high risk group of pathogen should be tested and reported through IDSP. The reason is when the cases are confirmed, they have to be they need to do the contact tracing. So if it is
Because
to
if it's-
private sector and if it is if they don't report to IDSP, the contact tracing will be not done.
Because most of the patient population goes to the private hospitals, right? So
If they suspect any cases, they can inform immediately to
So it could
by
be late.
IDSP.
My point is, it could be late before, the spread should happen more rigorously. But why isn't that happening in that
In
case?
the Kerala, they have 5 active, in Kerala, they have 12 VRDL laboratory who can do the testing of DFA. So they can, and Kerala is not a very big place. So they can immediately send the samples to the VRDLs as soon as they, and they take all the private samples without any charge. In West Bengal also, we are not doing this respiratory illness syndrome. So we have put all the laboratory, VRDL laboratory, because you also need to assure that biosafety. Because if anybody and everybody will start the testing the sample will be stored lying on here and there. So you also need to, and these are the bio threat actually. So it should not go and lie somewhere to assure that. That's why when there is a suspected sample, it go to at least the BSL2 laboratory or BRDL so that they can handle this samples properly, store it, discard it. So those kind of minimal protocols should be. Most of the private labs, they do on the table if you, meantime, they are not having PP also. So they also bring a lot of risk.
Thank you.
Thank you.
Sir, I'm having one question for Dr. Gill. Sir, why, this use of antibiotics, in one of your slides, mastitis is the highest, but in the other diseases, it's low. So what's the reason? It's available readily. MRs are directly selling to the farmers. Bigger farmers are advising to the lower ones.
The livestock works on the economics. If the milk production is reduced, if the animal is in a fever, is a lameness or anything else, he will not call immediately the doctor. But if the milk production is 10%, 20% reduced, And there are chances that the complete blockage of udder loss. So immediately the farmers know it's a very serious thing. So first of all, he himself gives the medicine because everybody know for the mastitis they are giving antibiotics. And the antibiotics are given for the long time. The intramammary drips they are given for for 5 to 7 days. So the maximum use of the antibiotics in the two things, the reproductive disorders and the mastitis. If you see that the animal has a fever or something else, there are the good chances of third or fourth day they can recover without any treatment, without any antibiotics. And many of the times the owner didn't even come to know that the animal is in a disease till it stopped eating. So, but for the milking, every day he go for the animal milking. If there is some shreds in the milk, he immediately diagnosed the mastitis is there. In the reproduction, some discharge from the vagina, he came to know. But till the animal is off it for 2 or 3 days, people do not go for any treatment, except for the big farmers. That's the main reason.
And second point, sir, from these One Health presentations, sir, what fungal diseases from the plants. So this part is, I mean, plant system no one is touching. What's the reason, sir?
So that's the things of priority.
Like fungal diseases, no? Tomato viruses.
These are they are in the aflatoxin toxins, aspergillosis. The aflatoxin is the priority disease, the fungal. It's one of the fungal infection, aflatoxin. This is in the top 5, 6 foodborne disease. That's the aflatoxin M1 and is in the B1 in the feed and M1 in the milk. It is among the top ones.
Top one. Thank you, sir.
As the one hand, it has been prioritized as well,
Yeah.
but because they are not part of pandemic preparedness, so
Prepared.
that's why it's not presented here. But fungal diseases are very much in the scale of.
Ringworm is the one of the
Priority
most important
diseases.
zoonotic disease.
Yeah.
The ringworm.
Okay.
Thank you.
My question is to Dr. Pragya. Thank you for this informative talk. So you mentioned that you have recently started this big collaborative project on surveillance in slaughterhouses. So what are the diseases you have considered under this program and what is the basis of selecting those diseases?
So, very good question. Maybe sir can also give the input. So based on the, so there are certain known pathogen, zoonotic known pathogen in the country, which is being detected. And that has a huge list of bacterial pathogen. But in the past, we did not detect, for example, slaughterhouse, human interfaces. So we have included bacteria, viruses, and also some of the fungal pathogen actually for the, and then there was a scoring to them as per the country's need. So we have one World Bank project, which we call deliverables, DLIs 7 and 8. Under that, the countries, every state was scaled based on all the publication which we have, and the priority pathogens list were made. That is a very big list, but at least top 15 pathogens to be considered for testing. But there was some discussion, then there were discussion, multiple time discussion, and further discarded some of the pathogen which maybe rarely come, or the prevalence is very poor, or maybe it is not relevant. So based on all the discussion, these pathogens has been decided by network to be tested under the program. I'll request Dr. Gill to add if he wants to add something.
When we are making the priority diseases, there is absolutely a difference between the medical and the veterinary peoples.
Yeah.
The mortality is the number one
Yes.
priority for the medical people mortality. But in the livestock, we consider morbidity as the number one. Because the number of the animals, just like a FMD, just like a brucellosis, the lot of the morbidity death rate is less, but the economic losses are more. So we have to make a balance between that mortality and morbidity and the transmission. The easy transmission from one animal to the animal or animal to the human being. So we make this during both the Jaipur and the Odisha meetings. We make the balance between that. We should consider mortality, also the morbidity, and third is the transmission. Transmission to the human being is that zoonosis is the important one, and transmission to the animal to animal is also considered as the one of the priority. On basis on these four programs, we made the priority list. Otherwise, when the initial work exercise was done, none of the diseases were from the medical people are in the list of the veterinary, the livestock.
Right.
So then we have to make a homogenization that considering that this thing.
So,
So they
yeah,
consider scrub typhus as the number one.
exactly.
So we make brucellosis as the number one.
Mm.
So in the brucellosis, all the data which they are considering were not included in this. So we had to make some points are given the weightage of each point, according to which the 10 lists are prepared.
Can we know that list so that?
So I will share it. I will share it.
So whenever we actually in the past, whenever we did a priority pathogens for human being, which is having the highest mortality with the lowest amount of pathogen and the route of exposure, these are the three main criteria which we consider. But at the same time, if a case of Nipah happen, the kind of economic losses it will happen, maybe some other disease won't cause even if the 1,000 of the cases happen. So that also depend like how much scare or panic is created by disease. If you close all the school, business. So in 2018, when the Nipah outbreak happened, people had the rumors. If you eat chicken, you will have the Nipah. So all the chicken business closed down. If you eat the fruits, because Pteropus bats a tendency to eat, so all the food business went down. And then nobody will go to Kerala, which is a tourism place. So you also need to calculate kind of burden which is causing on their economy. Recently, avian influenza, it was a huge loss in Kerala just because of avian influenza outbreak in ducks and those birds. So we also need to calculate how much economic losses. But for the human health and animal health, the calculation would be different. But if it is a zoonotic disease, then the picture will be totally different.
So there are some direct losses. That's the cause of daily loss, DLY, daily loss, that's the direct losses to the. But there are many indirect losses, just like I'm shown in the many disease, the tourism, mine worker, daily income. So we have to calculate these things and to the business also. So if we declare FMD outbreak in Punjab, and it is officially declared, all the product from that meat and milk export is stopped. So we have to recheck 3 or 4 times that the FMD outbreak has been there. And that is a major reason that people do not even report that FMD. Many states till it's spread to many major areas. The FMD is not reported in any state. If you go for the portal of the OI, that very few reports are there, only because the business loss, economic loss, the same day, if the avian influenza case is there, the poultry price, the meat prices from 300 kgs decreased to the 40 kgs in the same day.
Yeah, I remind you lumpy skin disease, which cause a major havoc in the cattle. And even Maneka Gandhi released a video that nobody should drink milk. But actually, so far, there is no record to state that it can transmit to human being. So we also need to wisely estimating that what is true information, what is true not. So that's
immediately on social media, we make the videos, we make the press reports that there is no report of that.
lumpy skin disease, yeah, in the human.
Thank you.
Thank you.
Thank you, sir. Thank you, ma'am. Thank you so much.
With the permission of ma'am.
No, please.
Gurudhara Veterinary University has a very good infrastructure, and especially we have 800 animals, large animals, poultry farm, piggery farm, goat farm, and very good field experience. In the many of the interactions with you, I found that you are doing very good lab work. If we need any collaboration from Vasu on field work of the experimentation work, the my university is open for that.
Thank you very much.
Thank you, sir. Now I request our director ma'am to kindly felicitate the esteemed.
Just do it. Thank you so much, Professor Gill. That makes a lot. You're very generous, professionally generous as well. To Dr. Pragya, as correctly was mentioned by Professor Gill about rabies, So also since you are sitting in a very important institute and making that nation one health mission, So from the animal sector side, if this message goes loud, that if you break the chain, and as we all know, more than 60%, if you break the chain, that will be also, the game winning will be shorter race. So this is from NIB side, I can just request. And second thing is, Professor Gill is aware about our ecosystem and work. Maybe just to let you know, since you were talking about a lot of work about bioinformatics and all, I may like to inform that the group of bioinformatics, so its number doesn't matter. What matters is how much we deliver. So this bioinformatics group at NIAB is doing very well. So in case of the need, please feel free to reach out to us. Yes, surely. That's one. And secondly, we do have a group of nanobiologists, including nano delivery people. So as rightly said by Professor Gill, because he's aware about our ecosystem. So, there are very many things which are happening. And one of our colleagues has started working on adjuvant delivery and going to strengthen that. So these are a couple of things. I mean, just for the for limitation of time, I did not present institute's profile for you. We will discuss. Thank you. Now I'll do the pleasantries, Himanshu. Thank you.
I request Director Ma'am to kindly felicitate the esteemed speakers for today.
From all of us. Yeah,
Thank you, ma'am, for inviting us.
Thank you for making it,
Thanks for the, thank you for spending the time.
Dear all, as we are aware, last week, two of the most celebrated, decorated, and wonderful scientists, Dr. Rohini Godbole and Dr. Manju Sharma ma'am, left us for the heavenly abode. The loss has created an irreparable void, and it is indeed very personal. Their works have left an indelible mark on Indian scientific landscape and have touched the lives of many professionally and personally. To offer our condolences and respect the departed, I request the NIB family to kindly rise up and hold silent prayer for a couple of minutes. Thank you. Dear all, as we conclude this celebration of One Health Day, it is my privilege to extend our heartfelt gratitude to all those who have contributed to the success of today's event. First and foremost, I would like to express a sincere thanks to our Director Ma'am for her unwavering encouragement and support, which continues to inspire us to strive for excellence in all of our endeavors. A special word of gratitude to our esteemed speakers for today's event, Professor JPS Gill sir and Dr. Pradnya Yadav ma'am, for graciously sharing their valuable insights and their time to enlighten us today. We are deeply grateful to all our colleagues and heads of various sections, administration, finance, stores and purchase, engineering, security and housekeeping, whose efforts ensure that every detail of program is executed flawlessly. A special appreciation goes to the students of NIB. Your presence have elevated the importance of the event. Last but not the least, a special vote of thanks goes to all the members of Scientific Event Management Committee for their efforts in coordinating and organizing this event. Thank you all once again for your participation and support. Now I request all to please gather at the podium for a group photo, which will then be followed by tea. Thanks. Thank you. Please gather for a group photo.
Thank you, everyone.